No fucking way. You know, if I was an Italian, some Italians, what they do is they extract teeth in order to level the bone interproximal. But if you fail, you have extracted good sound teeth. No way I'm going to place implants in here. First of all, it's periodontal prone vision. So in these cases, what I do is a bridge. I do a 6-unit bridge and finish the case. Okay? You can see the bone defect. Here we did many things. I did some extrusion beforehand to bring the soft tissue. The best surgeon is your orthodontist, because you can extrude the soft tissue, so it will be much easier. We did 2 times connective tissue graft. We pulled, I didn't have enough soft tissue. One of my bigger mistakes here is that I intervene too fast. Every time I place bone, xenograft material, at least I wait 8 months before I go back and start pushing the tissue. Okay. Here, I waited 4 months, so the bone is mushy poo-poo, so it's moving around, so I had to go back and graft again. Okay. So I graft from the palate, everything is tunneled, and in the afternoon I will discuss how we do it. But basically, everything has been tunneled, the tooth has been positioned exactly where we want it, and we pushed it around. 4 months later, this is the final pontics. I don't do avoid pontics when I have one pontic next to the other. It's a waste of tissue. So if you have the volume, it's a little bit of a rich lap. Everything is by pressure. So I do many things differently from what I was taught. Because if you want to do avoid pontics, more than 3 avoid pontics, one next to each other, you need way too much volume of tissue. But with one, it's okay, but more than one, it's a problem. It's not the topic, but this is where we started, where we finished. Okay? So you have 2 pontics in a row, with papilla in the middle, okay? And this is the situation. Okay? What about this one? This is a trap. What would you do? I would never place an implant in here, right? The tissue interproximal is gone. I'm going to do a rich preservation. This is 2 years down the road. No matter what you do, you're going to have a collapse. So we do connective tissue graft. You can see the papilla is level, very much. Fistula, crown. What do I do? 4-unit bridge. Simple, predictable. Okay. An implant in there, in between crowns, is a pain. And then you will have movement of the teeth. She's a class 2. So bridge sometimes makes it better. So let me look at interproximal bone loss. Usually, if the interproximal bone loss is in between 2 teeth, it's okay. But if I can place implants, but if the bone loss interproximally is in between a tooth and a tooth that is going to stay, it's a problem. But if you have the bone defect in between, the unilateral bone defect in between 2 teeth that need to be extracted, maybe it's possible. Let me share this one. Not an easy one, because on top of that, she's a dentist. So what would you do? Okay. situation, this is, she has no bone on the buccal aspect, no bone here, resorption, no bone, no interproximal bone. They try to get rid of the resorption, but those teeth are totally gone. So, difficult. So what would you do? Well, I would use 2 implants on both central incisor. But I will do something before the implants, which is connective tissue graft. Why is that? Well, I'm gonna try to see if I can improve noticing all the bone defect and bone problems. I'm gonna try to place a provisional restoration on both teeth, create more space, and do a connective tissue in between the teeth. Because doing a connective tissue against the tooth is easy. Doing a connective tissue against an implant is much more difficult. So in those cases where I have a defect, usually I do a connective tissue and I don't have a papilla height. I'm gonna try to do a connective tissue for extracting the tooth. Okay? And I try to set ideal soft tissue before planning the implants. So this is the provisional. I did the provisional with pink composite to have an idea how long those teeth were going to be, if she liked it, and then decide how much I have to advance the soft tissue coronally and how much I can think of it. So this is the situation, and this is the first connective tissue graft. So usually, the way that I do connective tissue graft, I do always an incision crestal to the bone. And I do a small incision on the, above the fornix, on the lip. And from there, I'm doing a full thickness flap, just to elevate my flap. The problem is elevating the in between the 2 teeth. Okay? So I brush, I try to create elasticity of my tissue, I create a space, I create a space in between the root, I go palatally so my tissue can move from buccal to palatal. I elevate the papilla without breaking my flap, which is important. And then what I do is I do full tuberosity in between the 2 teeth. I came from the back, going to the tunnel. You can see here I have the defect that we saw. Everything has been cleaned with laser. And then we're going to bring the soft tissue in between and plump it up. Okay? So I'm pulling from the palatal and I'm bringing the tissue maximally with the finger. I'm pushing it exactly to suture it wherever I want. Okay? And then I will suture the buccal aspect to thicken the soft tissue as much as possible in order to maybe in a second connective tissue increase even more the thickness of the interproximal. So usually when I have this type of cases, I try to build as much tissue thickness maybe in 1 or 2 surgeries before I go back and place my implants. Okay? So I will really easy go through. And then all the excess, the idea is to level it out. All the excess, all the tissue that is sticking out, I'm going to modify it. I'm gonna cut it. I'm stabilizing the buccal connective tissue. Simple, nothing complex. Drilling suture coming around the tooth, suturing against the root, okay, bringing it into the position. The flap is able to move vertically, and this little excess, I take all the composite off, I even modify how both, and then what is sticking out is just moved sideways, even improving more the papilla, and figuring out how much volume I want and position it. Okay? What is important also is the traction of the soft tissue. I hate Marcus Urstberg suture. I use things that are much simpler. I use suture from Gerardo Chacon, who is a guy from Venezuela, who lives in Colombia, and it's really simple, and you will see it right away. It's a simple, if you want to take, we make some contact points, and if you want to bring both papillas, I take palatal and mesial papilla, and I suture. I put my finger, come from palatal, I take my papilla, it is a single, it's what he calls the reverse single. I learned it from him. Really simple, it's just for stitching. Put the finger, I want more pressure. If the tissue is movable, you can bring the tissue. We go to the line angles, we push it again. You go to the other line angle, and you push it. Okay? Really simple. You go underneath the contact point, and you suture. You can take either the palatal or only the buccal flap, depends what you want. So it's really easy, really convenient. This is what it looks like. So this, how it looks, is about 2 weeks. Nicely. Where we started, provisional, 2 weeks. And then when he comes, I was pretending to do a second connective tissue graft. She tells me, Iñaki, I have a problem. What do you mean you have a problem? Yes, I have a fistula here. Rating, bad taste. I said, what? Maybe I have to jump into the implants because there's too much infection here. If I do a second connective tissue graft, I can risk to have a problem. So we decided to place the implants. Okay? You can see I placed the Gaborena marker here. There is nothing. You will see. So I'm planning implants, 3.5 millimeter implants. And the other issue is the more I'm placing my implants deep, the more I'm thinking on the transmucosal abutment. Why is that? Because if I want to increase the bone vertically, I don't want to be disturbing the connection of my prosthetics with my implant head. So I always use transmucosal abutments, multi-unit abutments. Okay? So let me share with you the surgery. And this is the surgery of the implant placement. So the patient has had already one connective tissue. Those teeth are totally brittle, they break, they are totally in bad shape. Okay? So I'm putting my finger, you can see all the cracks or the situation of these teeth. Just pushing, you can see the resorptions and how much infection we had in there. So I de-epithelialize the circles, really important, because if you don't do that, you will have scars. I use whatever is in my hand to disinfect, to clean, not only the bone, but also the soft tissue from, I use also carbides, everything that I have into my hands to make sure that I got rid of all the infection. Okay? Not only from the inside, also from the outside. I de-epithelialize, you can see the collapse. I don't have the proximal bone cervically. I don't have a palatal bone, so I will have to reconstruct buccal and palatal. So here we use a membrane from pigs. I use the one from Osteobiol. It's called Lamina Soft. It's about 0.8 millimeter in thickness. It's a rigid, semi-rigid membrane. So I will do a cut of my periosteum at the base and a cut at the periosteum vertically in order to have all this soft tissue moved. So this is the membrane that goes on the palatal aspect, and this membrane will go on the buccal aspect. So the membrane is tagged through those little holes into position to reconstruct my bones. This is from Osteobiol, and then I close it, and then I will place my implants, just one pair, to place my 3.5 by 50 millimeter implant. Maybe I will engage a little bit the penetration, or even 7 millimeters, so my implant knows where it should go. I check if I will place the bone in between the membranes. You can see one in the buccal, one in the palatal, in the middle. I will try to now create a little space of where the implants will go, with some water, of course, and then place my implant and pray to get the 70 Newton. I'll go and then figure out how deep I want those implants to be. Usually the depth is 5 millimeters, 2.5 for my multi-unit, and another 2.5 for my connective tissue. So I'm packing bone all the way up to my implant, and once I have packed my bone all the way up to my implant, I'm going to pack bone all the way up to my transmucosal. Okay? It's a lot of work, and then once you have done everything, you reline your provisional, maintaining the emergence profile desired. Take it out, and now allow space for 2.5 millimeter of connective tissue. So this is a double trouser, one from one side, the other one from the other side. The thicker tissue will be in the middle. Okay. And we go from the outside in order to allocate exactly the connective tissue where we want it. So now the connective tissue has been taken from one side. Now we go from the palatal. Now we go from the distal part, buccal. So we orient our connective tissue before we insert it. Okay? So you can insert the connective tissue where you want it. Place so it doesn't go. I want the connective tissue to stay exactly where I want it. Sometimes I take advantage of my adjacent tooth to really place the connective tissue exactly underneath the papilla. So you can see the precise position of everything, so the papilla gets supported. So here is a long surgery because we reconstruct the bone with the lamina, we reconstruct the bone with the soft tissue, and the soft tissue is the most important. So you can see I'm checking with my finger, I'm allowing the space with my provisional. I'm taking it out, I'm just checking how much movement I still can do, if I can bring more soft tissue. So you can see I'm stuffing as much tissue as I can get from the tuberosity. This is one tuberosity. So I'm running out of tuberosity. You can see the space that is left from 2.5 millimeters. I still have to do one more surgery. It's not finished, but you know, we'll go after it. It's not easy. Nobody has said that dentistry is easy. And then I pull everything again, sorry, vertically on my tissue. I bring the palatal and the connective tissue in one shot. Come from palatal, buccal, and the contact line will stretch everything. I go to the line angles, depending on, you can see here where the fistula was. This is the case finish. Okay. This is where we started. This is 2 weeks for what? I take my stitches minimum 2 weeks, sometimes 3 weeks. The ones that are on the top ones, they go away the first week. This is the scenario of the cut of what we were able to achieve. Pay attention that the bone is flush with the multi-unit. I see a totally different result with the Z multi-unit as we used to have the titanium ones. This is where we started. This is the different X-ray. This is day 0. We're happy. This is 4 months. I lost some. This is 6 months. Pretty much stabilizing and remineralizing. I will, once I get back on Monday, after my Vietnamese trip, I'll have this patient to finish it up. This is how she looks 6 months later. And of course, there are many things I would love to change. First of all, my provisionals, okay? I would love to have an opening. I would love to increase my papilla in between the 2 implants. I want to improve the volume. Here I have mucosa. Here I have some keratinized tissue. So I will open space to improve both the papillas, but I think it's going in a good way to a success and a happy patient. So I will jump on normal relationship, and this is when I have a normal relationship, you can do many things. It's a case that we did the crown before extracting the tooth. So that means that the day of the immediate implant placement, I deliver the final result. We have many cases like this. We planted, so in type 1, you can do whatever you want. You can see depth here was crucial. And we do a verification jig, we do all the steps. And every time you deliver everything, same day, you see that the bone is totally disturbed, and you have a great result. So we always make a 360 degree connective tissue graft. As I've shown you, this is the final crown, same day. So all the work is done before. This is the bottom, the iPhone videos of 7 days, day of the surgery, 3 years down the road. So it works really nice. This is infection also on the adjacent tooth. We got rid of it, and this is what it looks like 3 years down the road. Many other cases, internal resorption, class 1, easy. So we did the crown before doing the implant. The problem here, we have a little recession. So on the recession, what we do is we do a double connective tissue graft, and I'll show you in a moment. This is the different videos, extraction, placement of the implant, placement of the final abutment, cementing, connective tissue graft. We use LPRF. It doesn't do anything to you. I prefer connective tissue graft. But we did buccal and circular. Please don't do one connective tissue graft to do the buccal and the proximal. I always prefer to do a separate, meaning a buccal connective tissue separate of the circular. Because if this connective tissue gets necrosed, you lose everything. So I prefer to do in 2 parts, and I'll show you more cases. Those are all cases, maybe now 5, 6 years ago. And delivery of the final crown. Why cemented? Because if I have a little distortion, I can use some composite on the adjacent teeth to have a nice interproximal contact, and this is the final result. It's important to de-epithelialize the sulcus. If you don't do it, you will have problems with scars. You can see the perfect symbiosis of the crown and cement, how perfectly everything is designed in a way that will have a perfect restoration. This is when we started 7 days. 3 years is your reality. If you don't graft, you will see your problem within 3 years. So, do I do a lot of this? No, I don't. Usually it's patients that believe on me, families, easy cases. So in easy cases, you can do many things. The challenge will be 2 implants. If I ever do 2 implants or bridge, they will be splinted always. I never do any more 2 single crowns on 2 implants, because I have cases where I have a diastema between 2 implants because of the growth of the suture. So I always split my implants. Today, this is the case was referred. They did extrusion, they did it wrong, the wrong way. There is no sound tooth structure, so we decided to place 2 implants. And the patient was easy to handle, so we jumped everything. And this is the surgery. Sorry, so fast. The surgery or the different stages and steps, pretty much the same. Packing the bone, and most important, elevating the papilla, thick tissue, easy case, controlling the disclusion of the patient. I perforated a little bit once I was doing the disclusion, checking the disclusion, that both implants receive the same load at the same time. Okay, it's really important. So sheep stock is crucial, and doing the pants and placing the thicker tissue where we need it the most, which is interproximal. Okay. So I suture the little defect there, and checking the disclusion, modifying the angulation, the angle of disclusion of the lower anterior teeth. She wanted long teeth because she was what she had on her teeth, placing the implants exactly in the same place that we have planned in the model. So you can see nothing is easy. To come up to this type of details and dexterity is not easy to overcome all the problems in the lab and clinically also. Okay. So this is what I received. This is provisional that I did. This is the crowns on the teeth before placing the implants. This is 1 week after the connective tissue graft. This is the same day of the surgery. This is 9 months. This is 3 years down the road. The tissue grew. Okay? This is typical situation. This bone that modifies. This is the iPhone video. This is the article. This is about 3 years down the road. And this is the look of it. Okay? So this 5 years down the road, we modified the soft tissue with laser, and this is a year later, the final result. Okay? So what about when we have a bone recession with a nice local bone, but this recession is 5 millimeters. Okay? In this case, I do connective tissue graft. I'm not pretending to grab the bone because it's more complex, and I try to make it as simple as possible. Okay? In those cases, I always do 360, and I also do the second connective tissue graft, which is here in the buccal of the bone. One around, one buccal, and every time you do this type of increasing the thickness of your soft tissue, I always modify my emergence profile to allow more space. Sometimes even I cut the abutment, the root, the same that I do once I have natural teeth. I cut the root in order to allocate more space for my connective tissue and maybe mask my dark root, for example. And I do the same with implants, and I'll show you the case. And because the most important, I did a research with Marcus Blatz, and what this research shows you that the grayish appearance of your soft tissue at the end is only the anatomy of your emergence. The emergence should be convex to the emergence profile of the tooth. As soon as you have a dissimilarity of your tissue volume compared to the adjacent tooth, you have a grayish appearance. It doesn't matter if you have a zirconia abutment, if you have 3 millimeters of tissue thickness, you have a problem. Okay? If you look at, read the Ronnie Young's research that shows you that if you have 3 millimeters of thickness, your eye cannot detect if you have a titanium or zirconia abutment. Well, you have to think that there is not a lip. Those pigs don't have a lip, they don't smile. Okay? And the problem is the lip. If your patient shows the soft tissue, you have the umbrella effect. It is more important the volume that you acquire on your tooth and your implant. If there is a dissimilarity, you will have a grayish appearance. So watch out. So those are cases we have done 15, 16, 18, 20 years. For example, this one is one totally independent on the buccal, which is sutured with one suture. The idea is that the soft tissue is sticking out of the socket and will go under the concavity of your crown. Okay? So the crown is like a mushroom, trying to cover everything underneath, which is hollow. Okay? This is 10 years implant. Okay? So this is the trouser, is a piece of tissue from tuberosity. What is important is to de-epithelialize the top and the sulcus. Usually is the distal sulcus on the second molar. And this is a block. And you make an incision in the middle with 2 obliques. So you have one leg, the other leg, and it goes around. Okay? The belly, which is the thickest part, you will put it wherever you want the most. On the buccal, on if you have recession on the interproximal, if you have an implant next to the one you're doing it. So this is the belly, and this goes around the abutment. Okay, you have seen it. Nothing difficult. So this is where we started. In this case, another recession. We did an internal bleaching. We leveled the occlusion, the disclusion, the protrusive. Okay, and this is the final case. Okay, nice papilla, nice volume. Papillas have been kept, even though those are inflamed papillas. Okay. So we go really fast from left to right, and you see here we did all the prosthetic modifications in order to bring the tissue to a more coronal position. This is only a recession on the tooth, so we divide the soft tissue in two. One will be for the buccal, this one, and then another one will go around the abutment. Here we use the final zirconia abutment. And we modify the root of this tooth. You can see I'm modifying here the crown and the zirconia abutment. Okay? So I never had any problems. This is how much we modify the root and how it looks like. This is the surgery. I won't go into all of it. I don't have time. These 3 months, and then we can compensate today with ASC, which is an amazing abutment for 25 degrees, and this is the final result. With the iPhone video. Okay. We did the internal bleaching, a composite, and we try to manage the same on the other side. Another one, a recession. The problem is we have to bring down the soft tissue to level the soft tissue and the canine tooth. Connective tissue on the buccal, around, and on the adjacent teeth. The problem with deep implants with Nobel is that if you want to use the transmucosal with Nobel Active, you have to go to on-one abutment. And the on-one abutment is way too big for lateral incisor, and then you cannot compensate for the angulation, so, which is a pity. So I will share with you some indications where I use what. But here everything has been modified with, you can see the ASC is way too big and too close to the implant head, so it creates pressure on the adjacent tooth. You can see 1 year later, we have lost the bone due to the pressure of the tail base. Okay. So this is the reality when we finish. Okay, usually it's full contour. So let me show now difficult cases. The recession where there is no bone on the buccal aspect. Okay? I have a nice scallop, but there is no bone. So they are all infected sites. Of course, there is one that is impossible to do immediate implant placement, which is this guy. There is no way I can anchor here in the nasopalatal nerve. There is no possibilities to anchor, so I have to do a delayed approach. And we'll talk about this in the afternoon. It's not immediate anymore. But the rest is the best articles out there talking about immediate and infected sites, and they come up with similar cerebral rates. Well, I don't like the pictures of what those guys are doing, but it's true that you can do it. Okay? I started since 2020 to place immediate implant placement on infected sites where there was no vocal blade or palatal. The only problem that is you need to look at which is the situation of the relationship between the tooth and the housing of the bone, the alveolar bone. So here, in all of those three, I can place implants because I still have bone to stabilize my implant, but in this guy it's almost impossible. Okay? So you need to know which situation is possible, which one is not, and the classification from Joseph Kahn really helps to have an idea. Of course, this is a delayed approach. We have to extract the tooth. I will share with that case tomorrow. Basically, it looks like it's when I placed it, and this is 7 years down the road, how it looks like. Okay? Just with soft tissue. Okay? So you can see 7 years down the road. There is two ways of getting rid of reconstructing the bone. These two techniques that I know of. One is from Jose da Rosa from Sao Paulo, great surgeon, who uses the bone from the tuberosity to wedge it in between the implant and the tooth. I was using that since I met Hannes Wachtel, and I like Hannes Wachtel much better than Da Rosa technique. And I will show you what I mean by that, and I will go directly on what I'm doing right now. So it's a case that I did Da Rosa. It looks this way. I jumped it on the veneer next to an implant 4 years down the road with autogenous bone of the patient and connective tissue grafts. We wrote an article because we see that we have a totally different way of doing it, the veneer next to an implant, but anyhow. You can see the value is the same, nobody can detect which one is the veneer compared to the implant, but what I want is to show this. Okay? This is the Hannes Wachtel technique since 2015. I started in 2020. This is from Osteopiol, it's an Italian brand that makes membranes of 0.6, 0.8, because they are done by hand, and these membranes are big cortical. They have some flexibility, and this is due to the demineralization of the membrane. So it's kind of, when you take it in your hands, it's like a cardboard, kind of. I don't usually wet it too much, because if not, when you tug them, you can break them. And the results that I have got are really good, and I want to knock wood. I have had 100% success. Okay? But you know, this is like soccer. I don't know if you play soccer. I was professional soccer when I was young. As a Spanish kid, I wanted to be a soccer player. I was not good enough, so I became a dentist. So what we do is we use this membrane to reconstruct the buccal bone, buccal or palatal, and I like to tag it. The tags that I use are from Miss Van Urban, really good tags from Messinger. And then I use bone mixed with antibiotics. It's very clean the socket with everything that I have into my hand. And I mix it. I've been mixing this for many years. I learned this from the maxillofacial department for sinus lifts. Usually I have much less questions with using antibiotics. You can use penicillin, you can use whatever you like, missing, you can use metronidazole, whatever you like. And I mix it together, and then I use, this is specifically for immediate implant placement on infected sites. And then I use tuberosity connective tissue, especially for only when I place the implant, or as I showed you before, when I want to avoid as much collapse of vertical and horizontal on the tooth prior to my implant placement. And usually this is something that I'm using lately, which is hyaluronic acid. It's called Dent PG. Sculian is at the base of this research, and I like it. So you don't have to, but it creates benefit. So the sequencing is based on your dexterity. Usually I start the tooth, and the original is you place the implant. You try to stabilize the implant, which is the most difficult part. If you are able to stabilize your implant, then you have all the problems solved. So every time we're going to place the implant, we pray, okay, we want to reach 70 newtons, and then you construct on the round. For me, I always place the buccal lamina. I tag it, the original technique doesn't tag the membrane, but I have much better results tagging the membrane through a little holes, as you will see in a moment. Then I place my implant, do my connective tissue graft, and place my bone and my abutment, and I do local and circular connective tissue graft usually to compensate the volume loss and everything. Okay? So let me show you different cases. It's a case that I did a long time ago, and I finished this way. One jump. He has a canine. This is the first premolar. He has an implant, and the canine is included. So we center the midline with crown lengthening and connective tissue graft, and do 3 crowns and a veneer on the first premolar. And then he came 6 years down the road, and because he followed the bike, and I say, what's going on here? Yeah, I saw that a few months ago, and then you can see all the problem. So we decided to do this. You can see all the amount of bone is gone here. So we place our provisional first. I had already a thick connective tissue. So we're going to do a circular and buccal connective tissue to compensate all the resorption we're going to have on the day of the surgery. It's the day of the surgery. So I extract the tooth. I make an incision on the mesial where I think I'm going to place the tag. I don't want to hit the root. So try to have an idea where the tags are going to go, where is the defect. You can still see that through those little holes. I try not to engage the gingiva, the keratinized tissue, the mucosa, sorry. And you can see it helps you to have an idea. If you are looking, you are cleaning perfectly your site. And it allows you also to see how well you are elevating the full thickness flap. Okay? It allows you with the laser also to clean from the inside, the connective tissue and from the outside. So there are many, you can see the spine, and you have a better control on what you are doing. Okay? So let me. So we can place the board, the membrane, which is usually I placed it dry, but sometimes it depends the difficulty. Sometimes I went a little bit just to really be able to place it in. The membrane is just leveled with the gingival graft, gingival margin. So my connective tissue has to be outside of the below my flap and outside of the membrane, and inside the membrane around my other part. Okay? So you can see I tagged it where I think it was the best place, and then I go through those vertical incisions. You can call it vista or pinholes, whatever you want. No vertical releasing incisions. The vertical releasing incisions are done from the inside. Okay? And then you suture, and the rest you have seen it. Okay? So we have the entrance from my membrane. I place my membrane, I take my implant, place my implant, finish the case. Sorry, these 2 weeks. This is my provisional that has pushed the tissue a little bit more. And this is Yoshi, my technician, finalizing the ASC. This is the video of the final result. You can see all the connective tissue will brought it back. We did another connective tissue graft on the rest of the teeth, and this is how it looks like. We splinted everything because the teeth were moving due to the accident, and you can see all the volume even though we have lost. We have a canine, we have centered the midline, everything looks again in the same position, and where we started, where we finish, and this is the 5-year paper showing the retrospective series of cases. Is really nice. Okay? So I will jump a little bit because I want to show you a few more things. There is the repetition. Let me share this case. This is one of my first cases, just to show the complexity. This is a case where I have lost buccal and palatal bone. Okay? So I have a huge fistula here, and no bone on the palatal. The fistula is coming out here. So I decided to place an implant, because if I don't place an implant, I would have done a pontic, because I would have done a Maryland, or maybe I would prep the canine and cantilever mesially, because if you don't do any medial here, you are totally, you have lost everything. So it would have been a fiasco. And you can see here all the problems, palatally, buccally. I'm running off an 18mm implant and maybe anchor the implant to the base of the nose. Right? So it's a difficult case. What happened is the reality. I was not able to stabilize my implant, and you can see all the granulation tissues coming out, the fracture all the way down. And no bone whatsoever. So I placed my implant to the best of my abilities, but I was able to only stabilize my implant 7mm from the pregingival margin. So this was a problem, and So I said, what do I do? Do I leave it? Do I take it out? I said, I'm going to leave it. So I placed one membrane on the palatal aspect, one membrane on the buccal aspect. I tacked it, and then I placed bone. The problem is with novel active, you don't have, you can use a multi-unit, but you don't have anti-rotational, just from bridges. And the only possibility you have is only one, and only one is too big for lateral incisor. So, and then you cannot compensate for ambulation. So I decided to place a healing abutment and graft crestally and tell the patient, let's see, let's wait, and I will need another second connective tissue graft to finalize the case. Okay? So this 3 months later, and I said, well, not bad, I'm happy because I can improve the situation, no problem. So I went 4 months later and did second connective tissue graft on the buccal. I'm just suturing the buccal flap to the buccal, and the buccal connective tissue graft from tuberosity to the buccal flap, and then graft 360 degrees around my, you can see how deep the implant is, which is, I don't feel comfortable going directly to the implant head and then jumping my circular connective tissue graft around my implant. So this is where I finished. You can see before and after. You can see 4 months. You can see 12 months. This case has already 4 years. The implant connection is 7 millimeters away. I don't like that. I would have loved to have a transmucosal. So that's why today, when we are planning to have a deeper implant, we always are prepared with a transmucosal. Okay? And I'll show you cases in a moment. This is where we finished. This is the iPhone video when I finished. Palatal, buccal. This is 24 months. Okay. And this is 4 years. Okay. You can see the tissue grew back. Okay. So, really happy. So let me show you some cases with on-one. On-one is has many problems, but when do I use transmucosal attachment? Is when I'm planning that my implant is going to be deeper. When I don't have proximal bone, when I don't have buccal bone, then I will be using a transmucosal. When do I use an on-one? Mainly I use it on a central incisor, maybe a canine, never on a lateral because it's way too big. And of course I will use it on the posterior. Okay? We are clean and novel to come up with a novel active with N1 connection. N1 connection, you will get it soon, and I will show you some cases which are nice to look at. Okay? So you can see here N1. Compare N1 to novel active family. Is the novel active family compared to the N1. So this is on one. This is transmucosal 4.8, the same for a 3.5 implant. As soon as you get to a 4.3 speed, 5.5, way too big. You cannot compensate for angulation. You have only 175 and 2.5. This is the multi-unit. What is the difference from N1 to active? Active is 12 degrees convergence. This is 8 degree convergence. This is a conmorse. Is 2.5 millimeter long. So you have less bacteria here than here. You have a smaller base, which is 4.5. You have 2.5, 3.5, and 4.5 height. So it's great for single crowns. So you can use a nice narrow base on a really tight fit connection, but the macro design is poorer than the macro design of the non-lactive. Okay? So you need to be really careful the way that you do your osteotomy on this implant. It doesn't have the same initial stability as you can reach with your active. It's a matter of playing around. Okay? So the big picture, if I'm placing an implant, a deeper implant, that means more than 5 or 5, is that I always use a 2.5 millimeter abutment to 3.5. It has to be deeper. But I always have to think about 2.5. 2 will be the minimum distance for soft tissue grafting. The on one, on an LP is 4.8, on an LP is 4.3, on a white P is 6.5. You have minimum height, you have to place it palatally, you have to use a universal abutment, which means you have to glue a metal to your zirconia, and this is a problem for your value and have a nice result. Okay? So if you are not deep enough, you will have to confine the soft tissue, and this is something you have to do it yourself. Watch out, all my splinting is not extracoronal, it's intracoronal. I make a hole on the tooth. I don't want this thing to debond, okay? Especially like her. She's a class 2. I told her intentionally. My experience with external splinting is they debond. Why they debond? Because they have wear. The composite wear off. The composite maybe was not done on the best situation. So it debonds. So I do a trough, and then I place my implant, my cord inside, my wire inside. This wire is 0.18, and this is the situation. Basically, I want to graft above the implant level to the transmucosal. With the surgery, the connective tissue, the trouser, how usually when I have a recession on the rest of the teeth, I do first my implant. I'm not trying to do the recession of the rest of the teeth. You can see the bone is being packed. We want to graft, so you're going to move all the grafted tissue, and then you place your connective tissue around, so you can have both worlds. The tooth, the soft tissue. We modify the soft tissue. We clean perfectly the inside. We position it. If the tissue moves, you suture it. In this case, we didn't. But you can see that this implant was not deep enough. But we need to also take into account that we're going to bring all the rest of the soft tissue to a more coronal position. So you see that I don't do it at the same time because it's a longer surgery, and then the tissue cannot get exposed. I told you that before. I want to have it pretty much closed, and nothing can get exposed because it will necrose, and you will see more problem. This is where we started. This is where we finished. You can see in the second round of connective tissue, I graft the rest of the teeth to level the soft tissue horizontally. I regrafted my implant, so if you need to. So you have a second chance to make it perfect. And this is the iPhone video of the final case, right? So once we are back, I will show you a case with no vocal bone. This is the one with no vocal bone and no palatal, but still have some bone to really anchor the implant. And once we are back, we'll show you more difficult cases with the proximal bone, how we deal with them, and we'll go into the delayed approach and soft tissue problems and how to get rid of them. So I hope this morning inspire you, and I hope we still have one day to go and we'll be happy with the menu. Thank you and see you.